and welcome to the latest edition of the Gutsy podcast. I feel as if I've not been in a recording for a while. Even, well, I don't know. It seems a bit longer than it actually is. But now we are on episode 10 of the second series. Who would have thought? 25 episodes in. Absolutely fantastic. As always, thank you to everybody who has been kind enough to subscribe. If you're online just now, hit the subscribe button on your preferred means of gutsying, whether that's on Apple Podcasts, whether that is YouTube, whether that is Spotify. So yeah, it's been great. We've had some amazing guests on. We've got an absolute cracker on today. He's been playing hard to get, so we wanted him on for the first series, but he's such a busy guy that we've only got him now, and we've only got him for a very limited time as well, till he gets his helicopter back to Edinburgh, because that is the VIP style that he's become accustomed in. So a very, very good friend of mine, I'm very proud to say, and a top man in gastroenterology and in the IBD community. Welcome to Gutsy, Professor Richard Russell. How are you doing, mate?
Very well, thank you, Derek, and it's a great delight to be here. It takes me back to the days where we were doing remember within the pandemic where we had the setup, and I think the first one we did was in my dining room and my face was right up to the camera, and my friends kindly took pictures of that, and I look back on it and think, oh my goodness. But I think I can see how things have evolved into a very professional sphere now with the podcast, but it was making me think back to when we did those first events, and I think, is that where the podcast grew from, or?
Well, I actually forgot about them until you mentioned it there.
How rude.
Do you know something? Those, I'm going to push back on the professionalism, because those were very professional, because what we had to do, because it was in the pandemic, is hook everybody up at home, and our great friend John Mancini, hello John, he pieced it together so that we could broadcast out. But if you remember right, those streams were a lifeline for people then, weren't they? They
were, because there was a lot of misinformation about lots of things, but particularly for IBD patients back in the pandemic, particularly at the start. And with my technology ineptitude, John Mancini was still able to cope with it, and I think we're able to talk through things, present things, but I think most importantly answer people's questions, and that there were a lot of questions, and it was a very popular thing, but I think essential.
Yeah, no, I totally agree with you, and if I'm honest, it's something that from a personal and professional perspective from the Catherine McEwen Foundation, I'm really, really proud of that project, because we were getting phone calls, and there'll be people watching and listening that almost every day. I mean, the world was in panic, and for all that, and quite rightly so. But our inflammatory bowel disease community were like, whoa, that was a total horror show. And equally, the panic was like, kind of cranked up, because it was so difficult or almost impossible, pretty much, to actually get to speak to somebody at hospital side. So after quite a few conversations with yourself, we kind of took we took the hospital out of the equation and put it online. So it was phenomenal, actually.
Yeah, but clearly didn't act as an inspiration for your podcast, given that you'd forgotten about it.
No. I think it held the basis of it. It held the basis of it. I think the inspiration for the podcast is because, if I'm honest, there's not really that much out there that's pretty raw, honest conversation within our space. Yeah. That can educate and inspire, and and that's what we're about at the foundation, as you well know. And I think 25 or so episodes in, the feedback's been brilliant, really good. Well, what's been quite interesting? There's loads of people watch it, they've got nothing to do with IBD.
Oh, really?
Yeah. Nothing.
Well, that's good. Good for education, good for awareness. Brilliant.
No, it's fantastic. So, going back, good to have you here. And it has been difficult to get you, because I know how busy you are. Tell us, Richard, what have you been up to? What's been happening?
So I think lots of things are always happening, and apologies, you have asked me before to come on the podcast, and I've not been able to do that for one reason or another. Not the easiest place to get to, Wishaw, you know. Anyway.
Your helicopter dropped you off outside, Richard.
But I think the biggest thing recently has been we have every few years a meeting where we all come together from across the world for all health professionals working with children with IBD. And luckily enough, we have just had a meeting a few weeks ago where 800 people came from more than 70 countries.
Wow.
To all come together to really, and it's a special feeling when everybody comes together with a single purpose, trying to all work together to improve things for the children and the families that we look after. It was unfortunate we had to go to Sorrento to have that meeting. I'm not going to lie.
Yeah. So for those not maybe in the know, we have a bit of crack, and over the years, when I refer to your professional trips as your jollies.
You do.
Now, I know there's a professional aspect to these, and there's a lot happens at them. So tell us about your trip to Sorrento.
So it was a 4-day meeting. We had lots of presentations from all over the world, including people from South America, North America, Asia. So a real global feel to it, in Australia. And really what we were looking at is bringing all of our knowledge up to the same place. But there was a big sense of purpose from the meeting, because we're really, as a community, so we work, I suppose just to give everybody the background, so I'm lucky enough to be part of a European group where there are 30 of us from different countries in Europe who come together under professional umbrella of the European Society of Paediatric Gastroenterology, Hepatology and Nutrition. Say it backwards, it's a tongue twister. And then feeds out from there into 130 different hospitals across Europe. So quite a powerful network. And we've worked together really for the past 10 or 15 years, trying to really bring children's services to where they should be across the UK and across Europe to match up with the services adults have. And when we first started looking into it, we were certainly well behind adults. And just, I suppose, to illustrate the point, so for any new drug, and the good news for everybody in the IBD space is that so many new drugs have come, into clinical practice in the past 5 or 10 years. But the average time it takes so say we got a drug approved today for adults in Scotland with IBD, colitis and Crohn's disease, then it would be 2035 on average before people under the age of 18 could access that drug. And fundamentally, we think that's absolutely wrong for lots of reasons. But trying to change the mechanics of how that happens is very difficult. So we've come together. There are 2 main regulation forces in the world. So one in North America, which is called the FDA, and one in Europe, which is called the EMA, so the European Medicines Agency. And they're responsible for approving new medicines. It's changed a little bit in the UK since Brexit, but essentially they're the 2 big bodies. And last year, they produced a document to say, after we've been asking them for 10 years, engaging with them, to say things need to change.
Yeah.
And so we've put together a very powerful piece of work where essentially we've taken every drug that's been used in adults and approved in adults. So to illustrate that again, 14 new, what we call advanced therapies. So newer, specifically designed for IBD or inflammatory condition drugs have been approved in adults, and only 3 have been approved in children.
Wow.
And the average time it takes between those is a decade. And that means either children aren't getting the treatment, or they're not getting the treatment in the right dose, or any safety issues that there might be as a result of that aren't being recorded. So we've all come together and we've done this big piece of work which says, actually, bottom line, if you have a drug in adults that's approved and is shown to work, there has never been one where we've subsequently done the studies in children and it doesn't work. Like, it makes sense.
Yeah.
So the whole delay process for a lot of people is not needed.
So what does delay it then? And I think this is really interesting because it kind of goes, it kind of hits on one of the questions that I was going to ask you about. You know, I need to stop calling them jollies when we're talking like this. One of the
professional conferences.
Professional conferences, yes, we'll call them professional conferences. For the man in the street, for our children with inflammatory bowel disease, for our families, what is the end result? You know, what is the outcome for them? What's the impact for them? And I think by explaining this and the hard work that you guys are doing to get some drug approval, that answers that. Certainly one of the answers. But the question that I wanted to ask you on that, what is the reason it takes a decade?
So for traditional or standard drug approval, the drug trials to show that the drug does or doesn't work happen in patients of 18 years and over. Yeah. And that happens first. And traditionally, they haven't done any trials in children until they've got to that point. Right. So you do the trial, you show the drug works compared to no treatment or compared to the best treatment up to that point. And then only at that point they start the trials in children. These trials are difficult. They take 3 to 5 years to get people into them, to find the results, and then translate that back. So that leads to a false delay. And because we've done this big piece of work where we've shown actually you can take it as read, the drug is going to work. Yeah. And in older children and children of a certain body weight, then you can just use the dose of the drug in adults and give it to older children. So essentially what we've worked out is that for children aged 12 and over 40 kilos, just use the adult drug approval, adult drug dose, no delay at all. Or you can just include them in the studies in the first place. So at that first study where you're looking to do the trial of the new drug, just do it in those children, make sure they all get the drug and make sure they don't have too many investigations to go along with it. But I feel the momentum is changing. Good. And we really were able to publish the paper the day before the meeting, excuse me, that's brought all of that together. So we now need to wait on these two regulators that we've talked about to see what their response to things are. But we have a big global community all saying the same thing. And that's very powerful, because then if they kick back and say, we're not doing this, then the global community can come together and say, well, hold on a minute. You know, you're denying our patients and their families very good treatments. And if we have no access to them or limited access or incorrect access, that's a big issue for us all. So I think we may come to, you know, the Catherine McEwen Foundation and, you know, IBD charities over the world and say, can we work together on this? Yeah. And say, you know, we demand access to therapies on an equal basis. So we're not asking anything different to adult patients, but I think it's important that we make meaningful change.
So I think, you know, for our children and young people and families listening to that, to me, that sounds wonderful. That sounds really, really positive news. But in reality, when, you know, what kind of, can you forecast a time scale on when that can kick in?
Yeah. So, you know me, I'm an optimistic person.
You are.
People,
I have to say, you have to be. You're a Hibernian fan.
Yes, okay. I wondered, we're just over 10 minutes in, I wondered how long it would take Derek to say that, but
we've got a wee bit to go, and we will discuss this.
So I think the most optimistic person, who I think at the meeting was me, because we discussed the timeline at the meeting and we said, you know, now we have this in place, now we're all agreed, what do we think? So these meetings happen every 3 years, and most people, I think the realistic people, thought meaningful change will happen by the time of the next meeting, so 2028. I thought, to be honest, it would happen by the end of next year for some drugs in some spaces. Yeah. So that's what we're trying to, to push for. We have had some change, I guess, since then. So one of the newer drugs has been approved for children of a certain age, of a certain weight since then. So there is momentum, but I think that's coincidence rather than as a result of what we've done.
And who's leading the way with the momentum on this? Easy for me to say. To say, right, well, is there a group of people that have got this on that's one of their tasks.
So I think So the group we're part of it is definitely one of our main focuses. So we've been advocates for children's access to therapy, investigations, and other things for a long time. The equivalent organisation in North America is also on board, so they're called NASPGHAN rather than ESPGHAN, and the Canadian group are there as well. But actually, at this meeting, there are representative professional bodies from each continent, and they're all signed up to it too. So they said to us, why didn't you involve us in this? And we said, have you any idea how difficult it is to get a bunch of Europeans and a bunch of North Americans to do this piece of work, to work through it all, and then to produce it? If we added all of you guys in, it would, take 2 years, and that kind of defeats the point of it. So we're all aligned globally, and we're pushing this, and we're waiting now for a response from those agencies.
Brilliant.
I think what we can say is that the people who make the drugs, the pharmaceutical companies, are definitely on board with some of it, because they've already adapted the way that they're doing these studies to try and take account of what we've said. So, for example, one of the newer drugs, which isn't approved yet in adults, will start a trial this year, and it starts in age 12 and upwards. So that doesn't maybe sound a big step forward, but 5 years ago that would have been 18 and over. So we're already starting to see the changes, but the result of those changes is still going to take time.
I think for me, one of the great things about what you're explaining there is the collaboration on a global level. That's big news. I think that's exciting, and joined up thinking. It's a lot of good, strong common sense in there to at the end of the day get the best for the guys that are living with this every day.
And I think in parallel, we certainly have the all of the charitable organisations come together in a European way, including buy-in from the UK, and we have support from them. So they are advocating along with us on a kind of European level. So EFCA, they're called, and they are behind us, and they're saying these are the real consequences of patients not having access to therapy. These are the consequences for children and families. So
brilliant.
Although you think it's all jollyism, there is a lot of hard work, honestly, goes on behind the scenes and at these meetings.
You attended a football match, I believe.
I did. So I believe all wizards balanced everything. And with Scott McTominay playing at Napoli, it just seemed the right thing to do. And my kind Italian professional colleagues brought me a Scott McTominay top. So it had to happen.
Very nice.
So,
very nice.
And Scott McTominay scored and Napoli won.
God,
so,
my God.
So all part of the fairy tale.
Was it Napoli-Inter?
3-1.
What a game. What a game to go to that is.
It was.
All right, okay. So what about the atmosphere? How does the atmosphere compare to, well, you're not really not a great atmosphere, a Hibs fan.
So maybe Scotland games or Hibs games. The Italian atmosphere is different. They're very, I think particularly even in Italy, southern Italy has a different type of supporter, and they come off, Diego Maradona and, having him as their idol, and Scott McTominay's he's not trying to fill that space, but he's definitely he's
a big deal,
iconic player, absolutely. But the atmosphere was incredible. It didn't stop. They have so many supporters who are just, live and breathe Napoli, even more than I would say in Scotland, to be honest. And there are some passionate football supporters here. But
absolutely.
It was amazing, brilliant.
So let's go back a bit, Richard. Talk about yourself. You've been a gastroenterologist for 18 years.
A consultant, yeah.
Yeah, well, how long have you been a professor now? For a few years now,
Yeah, a few years. 8, I think.
Is it as long as that?
It's as long as that.
Wow.
It's as long as that.
Wow.
Can you not see the grey hairs, Derek?
I think you're wearing it not too bad. Honestly, I think yeah.
Thanks very much.
Which surprising. 18 years. First started in Glasgow, but
yes, correct. So
at York Hill,
the old York Hill, where we first met, actually.
Yeah,
so
we did.
I've spent most of my consultant career in Glasgow, and then 5 years ago moved back to Edinburgh. So I think in terms of the context in Scotland, I've worked in most health boards because of the clinics that run from the two centres.
Yeah.
So I think I probably have not a unique perspective on children's IBD in Scotland, but a broad perspective, I guess, having worked in both of those places and seen, I guess, a lot of the strengths of both places. But I think, in terms of what you said before about collaboration, I think one of the things that people look at in Scotland is how well we do collaborate with each other. So although there is, historical rivalries between Edinburgh and Glasgow in other senses, there's none of that, professionally. And we work together with colleagues in the north of Scotland and Dundee and Aberdeen. So we have a very functioning network. And I think what that's meant historically is that we are able to work in a way in Scotland that other people are, envious of, I think.
Yeah.
So, for example, in England, where the health service is set up in a different way, clearly the population is bigger. Clearly you have places like, London, which, outpace us in many ways, but they don't produce the kind of, work or output that happens in Scotland because of the lack of collaboration and cohesiveness. So I think in some ways, when you work in Edinburgh or Glasgow or wherever you work in Scotland, you're still working to the same model as you would be, whichever centre you worked in. Clearly, there are 14 health boards. They all have slightly different ideas and ways of working, but actually philosophically, we're all working as a network. And if one is struggling with one thing, so if IBD is difficult in one place, then we share our experience and work together rather than, in an isolated fashion and say, you deal with that and you deal with that, and there's no linking in between.
And that's highly commendable. And do you know something? When any of our healthcare professionals come on, I always ask them, always interested, why did you choose gastroenterology?
I guess with most things, you have an interest and then you have an opportunity, and both of those things happened at pretty much the same time. So I think, first of all, before I became a gastroenterologist, you decide whether you're working with, children's medicine or adult medicine, and that was an easy decision for me. It was from my very first job. I worked in the Children's Hospital in Edinburgh, and then it's just evolved from there. It's so enjoyable. It's such a privilege to be able to work with children and their families that I would never do anything different. In terms of gastroenterology, it asked me a lot of questions.
Yeah.
So I think when I saw patients with different problems and different conditions, I thought, how do we solve that? And I think one of the things with gastroenterology is it's easier than some other specialties to kind of complete a loop. So you see the patient, you do their test, you do their endoscopy, you look at their biopsy samples, you make the diagnosis, and then you move on with treatment. And from a professional point of view, it's quite a satisfactory loop of events.
Yeah.
And, so it started before I was a consultant, worked in England, worked in Scotland, different gastroenterologists, and it all came together really coming back to Edinburgh and doing my PhD with David Wilson, a professor in Edinburgh who set up the service here in the late 90s. He was unfortunate in having me as his first research fellow, so he could have done much better.
Funnily enough, he agrees.
And then Professor Jatsitsangi, so he was the gastroenterology professor at the Western General, and he was inspirational really in guiding me towards doing a PhD and really, cementing things 100% within my mind and within my career path.
No, it was always interesting because when we had Professor Gozer-Ho and Professor Costas on a few weeks ago, and I was asking them, and Gozer's reply was really interesting because he just said it was the challenge.
Yeah.
The challenge, which I found really interesting. So I'm always interested why you would choose a certain path, because there's so many, isn't there?
Yeah, there is. But I think the intellectual challenge is definitely there. And I think, for myself and Gozer and Costas, we all came into IBD at a point where we could see it was changing. There was lots of things we understood, but many more that we didn't. And I think we've all taken a facet of that within our own career and tried to pursue that. Gozer and me were trainees together, so we were doing a PhD together in the lab. I think he probably did a wee bit better than me, I would say. But
I think you were copying his work.
I was not copying his work. I was one year ahead of him, so he copied me. But I think, it's funny to think about, how things have gone from there. And I know, Professor Charlie Lees in Edinburgh as well. And, the three of us trained all together. And we reflect back on that and think, maybe it was quite a good training programme that, that happened there. And the impact it's had, subsequently 20 years later. So I think I would agree with Gozer, just the intellectual challenge which is there, and it continues to ask lots of questions as you progress through your career. Yeah,
definitely. Absolutely. It's ever changing, isn't it? Certainly from, pretty much the outside, looking in from a clinical perspective. Something that always amazed me over the years when you were in Glasgow, was the length of time that you commute, that you actually commuted, because you were working in Glasgow for what?
14 years. 14
years.
Yeah.
To do that day in, day out, like for anybody, not just in your job, I always was like, it's a long time to be going back and forth.
But it was a useful time. So I think you can use your time well, and actually commuting, I thought there's nothing you can do about this. Let's make the best of it.
Yeah.
So the embers of research, eventually being lucky enough to be a professor, came from that commute.
Yeah,
so
really?
ScotRail they've helped me a lot.
I know, you were quite happy with the delays.
little corner table and working away. So it gives you, I guess, a space away from, clinical work, and allows you just to think about research and other important questions, reflect on your day. I mean, would I have chosen to do it for 14 years? No, probably not. But I think you make the best of things, and as well as the opportunities, there are always barriers or stumbling blocks that you'll come up against, and I think it's how you deal with those.
Yeah.
Because you're not just going to have things working out perfectly for you, and I think in terms of resilience and time management and making the best of the situation you find yourself in, it taught me a lot actually. So although people just think I think about the basics of it, actually I saw it as an opportunity.
I think it's a brilliant way to look on it, to be honest with you, because I mean, a lot of people that talk about that commute or any commute, they see it as a bit of a curse.
Yeah.
But you've kind of flipped that round, which is.
Yeah, I mean, if you're in your car, you can learn Spanish and be confident in your holidays, or if you're on the train and you're working professionally, then you make.
I find that interesting. In your car, you don't drive.
I know that. I'm trying. Most people do though. So, and although the train fares have dropped, I think a lot of people would still choose to come on in their car. So I'm trying. They can listen to podcasts.
They can listen to Gutsy. Yeah, absolutely. So 14 years in Glasgow. I mean, obviously you were a big, important part of the team there. That must have been a tough choice, or was it an easy choice?
I think
to get your multi-million-pound transfer?
So I think there's two aspects to it. One is obviously professionally, and I think, professionally, Glasgow gave me, a lot of what I needed in terms of the intellectual challenge, the research, the collaboration, the setup, and although I would say, from when we first met at York Hill, moving to the new site was definitely a challenge. It still continued to be a good place to work on a professional level, although not working within a children's hospital environment it isn't as satisfactory, I have to say. Although people always reminisce about, previous things, I do think the setup within a children's hospital is relatively unique. And, going back to what you said about inspiration to work, with children in gastroenterology, I think if children's hospitals as they were didn't exist at that point, I might not have been as inspired, because they have a unique feeling. They have, people who cooperate and work in a different sense, and that was slightly diluted, by the move to the mega hospital in the south. I think on a personal level, it's much easier for me to work in Edinburgh, just for practical reasons, and 14 years was a long time. I think comparing the two hospitals, again, I think I'm probably one of a few people who have moved hospital twice. So the children's hospital moved after I came to Edinburgh, and I think going through that process with staff twice is a difficult challenge.
Yeah,
I think the scale of move in Edinburgh was different, and the scale of hospital we have in Edinburgh is different. So it still has a sense, even though it's also co-located with the adult hospital, because the site is smaller, it still retains some of the feeling of a children's hospital environment.
Yeah.
And we have a lot of children-specific activities that we can still contain within the children's hospital. So, and so does Glasgow too. But I think it's the scale, the scale of the new hospital in Glasgow is, out of this world, really.
Yeah, it's quite a place, isn't it?
Huge. It's huge.
It's very, very big. It's very big. What I will say is, I think the move is taking 10 years off you. You don't look anywhere near as tired.
Thanks.
So no, it absolutely did. It absolutely did. Where do you see? You've been gastroenterologist for many, many years. What would you say the main differences are now to what it was in the beginning? What are the real things that you're like within your journey that you're proud to be a part of within that?
I think the specialisation of services that's happened really over the past 20 years has been very important. So I guess looking back, there weren't really paediatric gastroenterologists until the early part of this century in Scotland. So David Wilson was probably one of the first, so kind of late 90s.
Yeah.
And then that has evolved. And I think for children with IBD, it's complicated sometimes, and you need to have someone who really has deep knowledge and experience to get the best result for children. And I think the way services have evolved to help people recognise that, the limitations of what they can do and at the point to pass on has been a big, important step forward.
Yeah.
So thinking back, a lot of children were not diagnosed in children's services, and that was very difficult. So you can imagine yourself as a young teenager going to an adult ward full of, unwell adults, and then having, the kind of procedures like colonoscopy done in a very adult environment really has, long-term consequences for individuals and their families. So being able, I suppose, to recognise within the Specialist Children's Hospital, we have paediatric gastroenterology services and all of the things that go along with them, investigation-wise, treatment-wise. We set up, so Porrig McGrogan set up the first dedicated IBD clinic in Glasgow. And that was a very smart thing to do. And I think establishing then those clinics in Aberdeen and in Edinburgh has allowed a specific focus on IBD that wasn't there before.
Yeah.
So you need to be in the zone, you need to be prepared, you need to have all of your things lined up to give children the best care. And if you're chopping between different issues, you don't have that as a doctor. I think the big change that's happened is really the great professionals that we work with. So specialist nurses, IBD nurses, I'm sure are probably mentioned on every one of your podcasts, but the difference that they've made to children and families is more than the doctors. And I think, they have a unique place, and I think that they, over the past 20 years have evolved to have, the most important role within the clinics. And without a dedicated clinic, then they can't, allocate their time to that. Yeah. So these things have followed on. I think what you say is absolutely on the money. When any time that we do our community engagement days, or even just in general, speaking to some of our families, or the IBD nurses, they're raved about. They're the Hollywood stars here, aren't they? Yeah. And quite rightly so. I think I've been lucky enough to work with quite a number of them, and and they're special people, definitely. Yeah. And they're really important. I think the nurses and the dietitians in particular being embedded within the service. Yeah. And there being a recognition that you need people with specialist knowledge and skills to then all feed into the team, because it can be difficult, to work out the best way forward for families, and working with the families and then other professionals within the clinic definitely is a style that has evolved, and I think gives the best outcome. I haven't mentioned psychologists, and they I guess were later to join in the team, an absolutely essential part of it. But it was nurses, dietitians, and then psychologists, which has joined. But I think where we are now, to answer your question, looking back 20 years, we have dedicated clinics, we have dedicated professionals with specialist knowledge of IBD to try and match, the number of children and families that are now dealing with the condition. It's not perfect, and there are definitely, things that we need to continue to evolve. But I think, looking back and, remembering how things were, I think, things are definitely better, and that, they've moved in a logical and sensible way, to the position we're in just now. Okay. I mean, I think, even in the kind of journey of the foundation, we can see that, the advancement, and, don't get me wrong, of course, a little bit of a roller coaster, so people move and all this type of thing, and that does have an effect. But I think we've got a service that's decent. Is there anything that, if you were to say, right, you're looking at the service that we have just now, Scotland-wide, not particularly at the Royal Hospital for Children and Young People in Edinburgh, where you're based now, is there what would you change? What would is there things that you would say, right? Well, these are the few things that that would really make a marked change that I would like to implement over the next, short term, medium term, longer term. Okay, is this a Harry Potter moment where we get a wand on the wish list? Aye, can I let you into a secret? What? I've never watched Harry Potter. Oh, right, okay. Have you seen them all? I've seen them all. I've seen bits of them. Yeah. I kind of know the story. Yeah. But, yeah. So I think what would we change? Well, I think one at the moment would be the style of care we want, and we've described so far in the podcast to be a realistic expectation for everybody across Scotland. So that means you have adequately resourced and including adequate workforce in all of the hospitals. And there's always ebbs and flows in that. I guess it's inevitable. But I guess fundamentally what we've seen is a very rapid rise, over those 20 years in the number of children with IBD. And we've struggled to keep pace with that rate of diagnosis and then all of the things that needs to go with it. And I think, I guess inevitably there's always going to be a bit of a gap because services react to things rather than, deal with things in a proactive way most of the time. And I think, a lot of the work that the foundation has done and is doing is trying to narrow the impact of that gap on children and families, because I think the gap is inevitable. So I guess my short-term wish list is just to have adequate services as we envisage them for everybody across Scotland, wherever they live, with equal access to services, equal access to therapies, and I guess being able to see the person that they need to at the right time. And I think, the level of expertise or the position they're in changes, and, we have to work within health board structures and other things. But if someone in one place can't help them, then, to be able to come somewhere without, lots of difficulties surrounding that, then I think that's an ideal situation.
I'm going to put you in a spot.
Okay.
Do you think that's achievable?
I do. I don't think it's unrealistic, and I think there is reasonable support at a health board level and at a government level to do that. So I don't think it's impossible. I think, children's IBD services are a very small part of, IBD services as a whole in Scotland. And I think proportionately, we've had some, things or support given to us that, for example, doesn't really exist in adults, and psychology would be, a good example of that. I think in the medium term, the thing that fundamentally would change a lot of things for a lot of young adults in particular is to work away from this kind of false divide that we have just now where, children and young adults are looked after in the children's hospital, then move to the adult hospital, and then there's a gap in services, for example, with psychology. I think there needs to be a holding position in the middle. So I think for people aged between 18 and 25, they need a different service to people aged over that. I
think that's quite interesting. So that's actually something we've spoken about on Gutsy podcast a few times.
Okay.
Is there a gap? Is there what is the opportunity there? Because there's definitely a challenge, but how do we implement that then?
So I think there is a model there. So you can have a young adult clinic, and my colleague Professor Nick Croft, who works in Barts in London, has exactly that clinic. So they run a clinic with doctors and staff from the children's services and the adult services between the ages of 18 and 25, and they work together in that clinic, and it works very well.
How do we do that in Scotland then?
We need to advocate for it. So it is an aspiration within the IBD blueprint, which was produced several years ago. We have spoken about it. So for, I don't know if people in the podcast will know about the cross-party IBD group, which exists within the Scottish Parliament, so meets 3 or 4 times a year. And it's certainly been spoken about, within that structure. I guess you can't legislate for it, but I think we would need to advocate to, the 2 biggest health boards in Scotland and say, we as an IBD community, professionals, families, charitable organisations feel that young adults are being given an inequitable service compared to where they've come from and where they're going to go to. And it's not for everybody. Not everybody needs it, but there are a core group of...
But I think you used the phrase inequitable service.
Yeah.
And that, out there and speaking to people of that age and families, that is the feedback, in the main. Not everybody, granted, not everybody. Yeah. But if I was to, and I'm just going to pick a number here, if I was to say that the people within a certain age demographic looking at experience of, being, that transition into adult, I would say that 90% of them feel failed.
Okay. I mean, it's a bit disappointing to hear that. I guess maybe.
I mean, I've heard on more than one occasion service falling off a cliff.
Yes.
Which I take no joy in saying.
Yeah. Yep. And I think over the country, the services that young adults will experience are different, and I think that inequitable is fair to use in that context. I think what we want is the same for everybody, but I think we would also recognise that some people need a different degree of support than others. So some people will go through that process that they're moving on in their life. They want to move on from the children's hospital and will move into adult services without an issue. And I think people are more likely to tell you about issues rather than say it all went fine. So I think the 90%, I completely believe you, but I think if we took a broad survey of everybody going through that, then that makes sense, right? Makes sense on a human level. But I do think we all recognise it on both sides, of the adult and the children's hospital environment. There is a need there for sure, and there's a model that works in other places. It would take a degree of commitment and a degree of resource to make it work. But actually, I think, if we looked at things, I think you would actually, in the end, potentially be resource saving, because what happens if you don't have that provision in place? People aren't as engaged with their teams. They aren't as engaged with their therapy. They need more emergency admissions, emergency appointments, and newer, more expensive therapies. So actually, it's false economy to say that from a financial point of view is the wrong thing to do. Fundamentally, philosophically, it's entirely the right thing to do. And I don't think anybody would, disagree with that.
Okay, so how do we do it?
Well, we continue to advocate for it. I think they're not going to listen. We've asked, and they haven't said no, but they definitely haven't done anything about it. And that was 5 years ago. I guess we can re-ask the question and see if things are any different. But I think we need support. Okay. And we need people to advocate for. I've had this service up until this point. I then needed all these things and didn't get them, and these were the consequences for me. So a personal story or personal stories are very helpful to illustrate what I'm talking about is theoretical, really. But I think it hits home to people when you can actually see, in people's journeys how it impacts them. So I think we need your help to be able to move things on, because the people in the health boards and the people in Parliament are listening to us but not hearing us necessarily, and we need families, charities, patients to then give that extra push.
I think that we should have that a bit of a sit down on that and just see if there is a way forward to do that, because we you quite rightly say that my experience is not the full experience. That's just what people are saying to me, and you're absolutely right that that people are more likely to talk about bad experience than say, "Oh, by the way, I had a great experience. That was great." You're not going to really hear from them, but it doesn't get away from the fact that there are considerable amount of people that have not got that, and if we can jointly, and I mean through the Catherine McCune Foundation, you guys, and everybody who's kind of on the same page, maybe formulate a plan of some description, we might make enough noise.
Yeah. I mean, I think there's a clear unmet need.
Yeah.
Exactly quantifying that unmet need. I think we'd need more work. But I think medium to long term, I think that is the thing that would fundamentally make the biggest difference to the patients that we look after in Scotland.
Well, we'll see if we've got a job. We'll see if we've got a job to do.
Yeah,
because we don't have enough.
Yeah.
No, I think that's great. Now let's go back a wee bit, because for not being a top gastroenterologist in the paediatric sphere, what are the differences in IBD between children and adults, Richard?
I mean, I think you'll see some of them, yourself, you'll have experience of that. I guess what we've seen in children over time is the number of children being diagnosed has gone up dramatically. And, we're lucky enough to have records going back to the late 1960s and being able to look at every year since then about the number of children diagnosed with inflammatory bowel disease, and have really been able to track, the rapid rise, particularly in Crohn's disease, but in IBD overall. So coming up to 12 times higher than it was in the late 1960s compared to now. So a huge and very rapid rise. I think, what we know from our tests and, when we first started to work with adult services at the Western General in Edinburgh, we decided to look at, how does it affect within the bowel, Crohn's disease and colitis in children and in adults. And what we showed very clearly was more of the bowel is affected in children compared to adults. So in children, the normal pattern of Crohn's disease is that it affects many different places in the bowel. So the large bowel, the small bowel, the stomach, that's common, really uncommon in adults. So to kind of give numbers, 40% would be children like that, 3% would be adults is what we find. So
that's quite
fundamentally, that makes a huge difference in terms of our treatments and in terms of things like surgery. So surgery is more common in adults because they have one part of the bowel affected. But if you're a child with many different parts, there isn't a solution to take one part out and make you better because you've still got those other parts going on. So fundamentally, the disease is, the word we would use is more extensive, so involving more of the bowel. And the same is true for colitis. So in adults with colitis, it often just affects the first part of the large bowel, so the kind of first third. Whereas in children, it usually affects the whole thing. So it means symptoms and treatments and everything, all stem from that.
Wow. And I suppose, I know, I'd be confident you don't know the answer to this, but I need to ask it anyway. Why such a huge rise?
Is
that the $1 million question?
That's the $1 billion question. So I guess we have some understanding, and our understanding compared to 20 years ago is better. So the way I would see this is a bit like a jigsaw puzzle.
Yeah.
And what we've been able to do really is to put the pieces of the jigsaw puzzle out, round the outside. So we have an understanding of what the picture looks like, but we're still missing a few bits in the middle. Yeah. So we don't understand the whole thing together. I guess, if we think about how, times are changing, then we can see moving to modern lifestyles definitely matches up with changes in how diseases are, including IBD. So
what would come under the bracket of a modern lifestyle?
Well, how do we live our lives now? So we have easier access to healthcare services. We have earlier treatment of infections. We have smaller families. We have higher rates of cesarean section. We have less breastfeeding. We have more vaping. Our diets have changed fundamentally. So there are lots of different pieces in that jigsaw puzzle that you're all putting together. And in essence, people want to find the answer. The answer is everything, not a single thing. So there isn't one thing that we're taking now, which is giving everybody, IBD. It's a combination of different factors all feeding together. And I think we, to try and take it back, and, the flip side of that question as well, if you've seen the rapid rise, how do we quell the rise, or how do we actually make it going down? So looking at IBD prevention is one of the things that we talked about at the meeting in Sorrento, and there are now 2 trials going on in the world where they are giving advice to close family members who have somebody with Crohn's disease in their family and saying, we're going to tell you to eat this diet, or, not have antibiotics, or we're actually going to give you IBD medicines before you have an IBD diagnosis to try and prevent you getting it. So there is it's kind of a reverse way of looking at things, is if you can reduce the rate, then that helps you understand partly why the rate was going up in the first place.
Yeah.
So I think in Scotland, we don't know. I think fundamentally what I would like to say to anyone listening is it's nobody's fault. And I think particularly for parents, when their child is diagnosed with IBD, there's a huge sense of what if. There's a sense of guilt. What if I'd breastfed for longer? What if I hadn't given that course of antibiotics? What if I had stayed in that house, or not gone to that school, or not had that meal, or didn't go on that holiday, or, all of these things. Fundamentally, you have to live your life and you make choices, and none of those, choices are wrong. And to be honest, there's, small things maybe you can do that we'll learn moving forward that would change things, but there's no blame, attached to things. Things happen, and there isn't anything you can do.
So almost like for an individual, almost like the perfect storm, or certain elements all click in. That might be genetics, environment, diet, and then whatever that is for one individual will be totally different for another, and it's like when that clicks, then that would activate the inflammation.
And they're the missing bits of the jigsaw that we don't have. I guess the bits that we do have, we understand the inherited element to it, and we know that if you have a close family member with Crohn's disease, then your risk of Crohn's disease is 10%. We know that side of things very well, and back in the day, I guess I put all my money on that horse and said genetics were going to give us the answer, but clearly our genetics have not changed over recent decades, and the rapid rise has happened then. So the genetics is there, the genetics we understand, and I spent a good part of my early career thinking the genetics in children would explain the differences that we've talked about in the way the disease presents, and I was completely wrong actually. So my PhD was based on that principle, and I proved myself completely wrong, but it was still a useful thing to do. But I did have one of those moments on ScotRail where I thought, oh really, this is all going in the wrong direction. But actually it led to
thankfully not the train.
But I think it's also important to acknowledge that you start out with these thoughts and you think this is going to be the most important thing, and you prove it not to be, but actually we learn.
Positive.
Yeah, it is a positive. Yeah. Positive from a negative, and it led to, to so many different things. It was the first time, to be honest, that we started to come together as a global community, because everybody realised actually, these questions, these scientific questions are not answered by doing a study in Toronto or in Edinburgh or in Scotland. We need to work together globally. So let's speak to, this guy here in Scotland, let's speak to this guy here in Philadelphia. And that's we started doing that from those studies. And then, spin the clock forward a few years, those networks are then what we use to establish some of the advocacy work we're doing today. So there's always a positive to take whatever happens.
I think for anybody, watching or listening, that's hugely exciting, for the fact that, it's not done just locally, it's global. And more the more incredible minds that are working on this can only be exciting for the future.
Yeah. I mean, I think the other bit that we haven't talked about, so I've talked about things, I guess, from a medical or a biology point of view, but I think we all recognise that, adolescence is a unique period in everybody's life.
Yeah.
And unfortunately, that is the commonest age where IBD, new diagnosis and impact, comes along. So just at the end of primary school, just at the start of puberty, and then you have all the, the GI and other symptoms coming in. So I think the impact at that stage of life is different to, to younger children in primary school, and different to, to young adults later in their life. So I think it's important to recognise that fact and have services which reflect that. And, it's going back to what we talked about before, to having appropriate services in a children's adolescent space where they feel comfortable. These are, difficult and invasive tests. It's not easy to have, colonoscopies done. And, as a self-conscious teenager, more now than ever, it's very important that that's done in a, in a careful way.
How have you, how have you seen over the years? Do you see a difference with your patients with the impact of social media?
I think yes is a short answer. I think it's hard to try and undo some of the different aspects of that, because we had, clearly at the time where social media was becoming more popular and ramping up, we had the pandemic, and it's sometimes hard to untie both of those things. Definitely the patients we look after now have, more a bigger mental health burden than they would have had it historically. I think some of that is because people brilliantly now talk about it more, for sure. But I think even with that, the stress that social media puts on young people and the pressures that come with it impact, into how they care for their IBD or their thoughts around IBD. Yeah. So, but I think, kind of looking at the journey, it's hard to untangle both of those things, but it definitely is having an impact now. I guess we talk about social media in different ways. There are lots of positives, and I guess I would call that proper social media or normal social media. I don't know if anti-social media is a term, but I think
absolutely is.
Is it? Okay, sorry. I'm not in the social media space at all, but I think then some of the negativity that comes with it impacts particularly on teenagers, because they are high users of social media.
I think as a world, we're the most connected we've ever been.
Yeah,
globally connected, but you're very disconnected in many ways.
Yeah.
Because we're stuck on the phones. It's an addiction.
Yeah. And I think we recognise that, and we've tried to adapt our services as best we can to that. I think we've tried to look at, so for example, we've done some work recently looking at social media listening, so trying to understand what IBD patients talk about in a public space, because obviously you can't have private access, and looking at how generationally that's different. So
that's interesting.
Under 25s are shockaroo bigger users of social media than older IBD patients, and what they talk about is slightly different. So mental health is the number one thing that their social media posts are about under the age of 25 with IBD. So not the IBD itself, but the mental health, consequences of that. So I think we kind of knew that, but we didn't actually. And I think the other thing is we took social media postings from all over the world. So not just UK, which we are used to, but the same patterns are there in North America, Asia, other parts of the world. So
but I also think it's really important to recognise that, that obviously there's a huge physical impact in inflammatory bowel disease, but it's the non-physical stuff, it's that non-clinical stuff. And I think that we're trying to support that as a charity as much as possible, but there's so much impact, just mental health, for a start, life in general, that the impact of inflammatory bowel disease goes so far beyond the physical.
Yeah, and I think the perfect storm is for that to happen in adolescence. When mental health and other things are a heightened period of your life anyway. So I think what can we do about it? Well, we have psychology services there. IBD nurses are very in tune about picking up mental health signals and then, referring on or providing resources. I guess, indirectly, what impact does it have on young people? Well, they're in an education space when they're adolescents. And I think, I'd like to, if I can talk about the scholarship program and the, difference that makes practically to people.
Yeah, I mean, I'm really keen to talk about that because first and foremost, it's something that we're super proud of. Do you know? So we're just beginning into a new year.
Yeah.
Do you know how long it's been going?
5 years.
No, this will be the 7th.
How time flies.
This will be the 7th year.
Okay.
Of the scholarship. So if you look back, you were involved in the initial conversations. Yeah. Shaping the structure for that. So it's moved on. Leaps and bounds. We've got our base in Edinburgh, Glasgow. I think I've seen the report, the most up to date report. I think the amount of areas in Scotland that's now covered, because we have a lot of online tuition as well, so that the geography's covered. It's amazing. But what I'm keen to ask you from seeing our kids that are going through that, the academic results that come from it are pretty incredible.
Yeah.
First and foremost. And that was why it was there, because the feedback was, when we were speaking to people, that they were either coming up to the exams or, had gone through the process that they'd missed so much school that sadly the education system just couldn't support them.
Yeah.
So the thought was always, how can we support this? Let's put something in place that can help you achieve academic success, because you're driven to do that, and you shouldn't be because you've been dealt a bad hand. Let's try and support that and not be discriminated against in any way, shape, or form. That the results that came through that, I'm super proud to say, are higher than the national average for passes for Nat 5 and higher, which is absolutely phenomenal. I think it was last year they were like 10% and 12% higher, which is astronomical. However, what we didn't think about, but we know now, is what the non-academic impact is. And you'll see that in clinic.
Yeah, and I'm sure I must have mentioned that at the start when we were thinking about this, the benefits would be, in both areas. And I think, if you think about the position, young adults are in when they're entering their exams, if they've been off school, it impacts on their confidence, it increases their anxiety. They're worried just on a practical level about, access to toilets or, sharing their diagnosis with other people. So there is the academic side of things. And I think, the common focus of discussion in, patients between the ages of, 13 and 18 is how's school going? How's your exams going? What's the impact? So it has such a bearing on them that you can imagine then, if they're in a difficult position, that then they have a route out of with, the scholarship program. It fundamentally just changes their whole view to everything, because they feel, a weight has been lifted off them. And I think I've seen now individuals go through the program both in Glasgow and in Edinburgh, and it just is such a positive thing for them to go through, and gives them, confidence and resilience. And I think at the time when they're then, going to be moving on from children's services, it has benefits in those ways as well. So I think the academic was the focus of it, but actually the non-academic benefits are huge. Are huge as well.
I remember I can laugh about this, but I was it was a great moment, but it didn't feel like it to begin with. And I think it was maybe so the first year was a pilot, so with a couple of guys go through it. Joe and Amelia, who did brilliantly and continue to do so in life, which is brilliant. But I think it was the second year, and the results came in, and we spoke to some of the parents, so congratulations and stuff like that. We now have events, that celebrate the end of the year and stuff like that, which is great. But at the time, we never. And the parent phoned me up. Obviously, won't mention any names. And she said, "What have you done to my boy? What have you done?" And I'm like, "Oh no, this is no good." And he said, and then it changed. He's a different person. And I'm like, "Whoa, what a relief!"
Yeah.
But she was really, really emotional about it, and because bless him, he'd got confidence. People were. I think when you go into the environment that Graham and the team at the Education Academy Scotland have created, it's very much a further education kind of vibe. That they're treated like the young adults that they are. They've got that freedom. I mean, it sounds like a basic, but it's not in a lot of schools. They can go up and down to the toilet as they will. There's, they are treated differently, and they feel heard and they feel understood and they feel supported, because a big part of the scholarship is to say, right, okay, well, how can let's understand where you are with your subjects. What have you missed, and tailoring the learning in the classes specifically for them. So it's phenomenal, and this will be going out just at peak time for applications. So if people, whether you're a parent or you're a young student, and we can support, so please get on to CatherineMcEwanFoundation.com, have a look at the scholarship. If you've got any questions about it, ask us, ask your IBD team as well, because it's as I say, we're going into 7th year, and it's something where it's making a big difference.
Yeah, it does, and we talk about it all the time in the clinic, to be honest. And we've seen people who have been through the program, and it's great. I think trying to encapsulate the whole thing, I think, is important. So I think 7 years. I thought it was 5. Down the line, and trying to but I guess trying to just summarise how many people have been through the programme, what impact it's had, so you can help show people it's an important thing to be part of, but then also show it's a fairly unique project, I think. So I'm not aware of certainly other IBD charities doing this, but I'm not really aware of other charities doing it as well. I don't know if you know. Or?
Not at the moment. I think the model is something that the Education Academy of Scotland are open to bring other charities on board should they wish. And we would absolutely invite that, and we would invite, our doors open to speak to them about it and speak to them about the model, because at the end of the day, you'd want to see as many kids as possible who is maybe be disadvantaged, shall we say, due to their health, that they can get a wee pucky up, as they say. Because these kids, I mean, they're phenomenal. They're so driven. Obviously, education's not for everybody. That's fine as well. Yeah. And that's something that we could probably look at in the future. But for those that want to do well academically, then it's absolutely there for.
Yeah. I mean, for me, it's about achieving your potential, right? And there are barriers that can be put in place with that, but the drive for our care and our focus is to maximise people's potential, and I think that this is definitely a huge step towards that. But equally, I see children with other, bowel conditions who would equally, find themselves in a similar place with a different diagnosis, and also children with different non-bowel conditions who would equally, benefit from it.
I think you've hit the nail on the head, and I think that's what we're about as an organisation, as a charity, is helping individuals, wherever they may be in life, to achieve their full potential as a human being. Yep. Follow that dream. Because you've got Crohn's disease, that shouldn't stop you being successful in life.
Yep.
And it's try to and that might be that you need a little bit of support through your education. Fine. That might mean that you need community support. That might mean that you need support mental health. It might mean that you need to go on a wellness walk, part of the wellness program. But all these things to come together to help you achieve, success and fulfill your potential. I think that's absolutely what we're all about. And if we can do that at a young age, then so much the better.
Absolutely. And I think one of the important things is to think about that and the impact it has on, young people's futures, is that if things go wrong at an early stage, it's then hard to pick it up further down the line. So if things can be put in place like the scholarship programme to then maximise the potential at that stage, then the lifelong consequences are less. So a lot of our drive is towards that. And, one of the things that we didn't get to touch on about children is they'll have this diagnosis for much longer than everybody else.
Yeah.
So, that we shouldn't lose sight of that. So the decisions we make, and some of that is medical professionals, which drugs do we use, at the right time, is important because, I suppose fundamentally, if you have an operation, you can't put it back in, for example.
No.
So we want to work with children and families to get that bit right, but also with adult services as well, and say, the decisions we make, you pick up the consequences of them, good or bad. So let's make those decisions together. And if we're in a difficult position, we now have great collaboration, and we've talked about it within children's services, but actually we've got great collaboration with adult services in most of Scotland now, and we can say, this 13 or 14-year-old patient's going to be your patient in 3 or 4 years' time. We're facing a major treatment decision here. Can we talk about this and make this decision together? And, the ability to do that now is easy, both in terms of technology and in terms of, willing cooperation from adult services. And that has been a huge step forward.
Yeah, and I think from a charity side of things, if we speak about Catherine McEwen Foundation's involvement as as a cog on that very big wheel.
Yeah.
How can, from your point of view, how can we improve? How can we do better? What would be your input? Now I know you've been on our board, and thank you very much for that, by the way. So you've had a big steer on where we are. But you're not there now. You've served your time, so to speak.
Yeah.
How can we do better? How could you see us, moving forward to the benefit of our community?
I think...
Be kind.
Of course I'll be kind. But I guess what we can... it's been really nice having a discussion today. And, I always remember back to where we first met around the fire in York Hill with, Richard Driscoll, and where the charity was then doing very good work. What a guy. Doing very good work then, and kind of how the charity has grown and evolved, and then become a formal charity, taking that big step forward. I think obviously there are clear plans, for the charity with Katie's House, and really concentrating, having a hub for all of the the different spokes of what the charity's done so far. And I think that I think it's a bold project, and I think I told you that at the start. And
I think you used the phrase "very blue sky thinking."
Well, okay, that was the phrase. I must have been feeling corporate at that point.
That was the very phrase you used.
But it's good to to push for something that definitely isn't there. And even me as an optimist, I thought, is this really going to work? But I think it's is very much moving in the right direction.
Do you know something? Just and I could, when you were probably one of the most. I'm not saying no. I need to get this right. You were one of the people that was less enthusiastic, but you were enthusiastic. You're less enthusiastic just due to being realistic, I think.
Yeah. And
because it was a little bit out, well, probably a big bit out there, wasn't it? Just a wee bit out there. And I think as time has progressed with I'm inherently an impatient person, but I've learned a lot of patience during the journey of what this is, because what is it that, glaringly obvious was that when that idea's there, you're miles away from being in a position to be able to do anything like that. Miles. miles. So, a lot of work has to be done internally on the organisation, on the charity, on the structure of that, and get right people in place. And we're still not there, let me tell you, and you'll know that. But what has happened over that period is that naturally things start to drop, and you refer to jigsaw earlier on, parts of our particular jigsaw start to fall in place, so it starts to fill up, and you start to see the picture. And there's, that dream and that vision of probably 4 or 5 years ago or so, something like that, is definitely a reality.
Yeah.
But there's still some things that have to click in, and you have to let things take a kind of natural progression.
Yeah. And I guess how we've worked well together is we both have the same focus and drive for the end delivery, but the way that you get there is slightly different. And I guess I was, your natural enthusiasm and drive and progression for the charity is fantastic. I guess what you've politely said to me is I'm a reality check at some points, and not to take that away, but I suppose to match up with how things work in practice, how that all of the steps need to be in there.
Yeah.
And I guess we've both learned that from each side. I guess in terms of what can the charity do, I think a lot of what it's doing is fantastic and transformational, to be honest, compared to I guess more traditional charities which will support mainstream research, for want of a better word. And I think what stands the Catherine McEwen Foundation out is the practical impact that it can make to children and families. I think don't forget where you came from would be one of my bits of advice. So I know there's a big drive towards Katie's house, but don't miss out the other bits of what you've done very well as a charity to this point, because when you have such a big goal in mind, you can become very focused on that goal and then miss out on some of the other things the foundation has done, like family and education events, the scholarship program, the mental health program, and other things. So I know they kind of tie together towards that aim, but I think there is the potential for distraction and not losing sight of what makes a difference now to children and families in Scotland.
Absolutely, and I think firstly, thanks for that. But I think we absolutely need to be aware of that, because you can't be distracted by this big shiny thing that's essentially going to have a huge impact, but it has a home for everything else that you're doing, really. But all being well, that our first base in Glasgow, our first Katie's house in Glasgow won't be the last. Yeah, and we'll take them. We'll take them around the country.
Okay.
I'll be well, Richard, but one step at a time and all that.
Yeah, exactly. And I know you're an excitable guy, and that that's fantastic, and that's how things have moved forward. But I guess just take things one step at a time.
No, it has to be, as I say. But if I'm certain people laugh at this when I say that I've grown patience, but I definitely have, because you need to, what I've understood is parts of that jigsaw have come into place. You see, that had to happen for that to happen to get to the next part. So even though we would love to have the doors open, that's not possible, and for the right reasons, it'll take a bit of time to get there, and and it absolutely will get there. Yeah. But we can only do that working as teams, working as a team, and for at the end of the day with our community at the centre of everything that we do.
Yeah, definitely.
Most definitely. Where are you off to next? Where's your next jolly? Sorry, professional conference. What's the next one?
So I guess in part of the role that we do, we're keen to educate the future. So we run what's called an IBD masterclass for trainees across Europe, and again, without going in too much detail, the health services in different countries are very diverse.
Yeah.
And what we've been trying to do, I guess, is to have an average standard for everybody, taking into account all of the, the caveats which exist in, Eastern European countries, Southern European countries. So we're holding the masterclass for 40 trainees from, I think, predominantly Eastern Europe, in Croatia, in December. It's really fun to do these. So they run over a couple of days. They really
does this particular thing happen? This particular one?
So it happens every year in different locations. And what we've tried to do is to take it to different geographical locations. So, some places in Eastern Europe really aren't well resourced for their IBD or their education.
Yeah.
And so we've tried to, take account of everybody who's dealing with children with IBD. We tried in the first year to take it to Russia, but you can guess what happened in that year. So these are some of the, the bumps that come along. But, fundamentally, it's great fun to do. It's very challenging because they'll ask you lots of questions that you've never had before. So these are all people who are pre-consultants usually, who are training as specialists in IBD, and we want to cement their future so they can bring us difficult cases. We go through the latest education with them, but the masterclass format is like, direct feedback. So we can have long, discussions about really whatever they want. So, and it's all, in different places. So December in Croatia is the answer to your next question.
Whereabouts in Croatia?
Zagreb.
Have you been taking a football match?
No. Well, I've not organised it yet. Good idea.
Yeah, well, I feel that should be part of what you do now.
I like that.
Yeah,
like that.
I'm here for you. I'm here with the ideas.
Thank you.
Don't worry about that. That sounds really interesting. I think it's great for people to kind of out with your world and your sphere to understand that the levels that and impact that you have out with the hospital, because it's pretty significant.
I think we work together as a community, and I'm privileged to be part of that community. And it's, it gives you lots of opportunities for learning and for research and other things that wouldn't be there otherwise. But most doctors and health professionals aren't just about what they do in the hospital environment. It's about other things that go on in the background. And, a lot of the public don't know this. Yeah. And I think maybe there are some misconceptions about, what goes on at meetings and other things. But I think what we've talked about today is the genuine drive that lies behind them.
Yeah, because what's really interesting for me to listen to, I know we have a crack about it and it's just a bit of fun, but there's a genuine impact of these events.
Yeah.
A genuine impact.
I would say, more and more we want a meaningful output from them, and something we can say, we all came together then, this is what we all agreed on, and these are the consequences down the line.
Yeah. So when you go into, say, you're planning Sorrento next year or the next year's Zagreb, or what, that does each, do you go into that, or the organisational team or whatever the case may be, do they go in with a, this is the plan and we would like certain outcomes from it?
Yeah, I mean, some happen coincidentally, some happen, some are managed, some are, it's just where things are at the time. But, there's lots of people thinking about this in the background, and with all of these things, different ideas come in at different stages. And I think, the spirit of cooperation and collaboration is there throughout everything I do.
Yeah.
And I think what I learned very early on was, having a kind of self-centered interest and just doing things in your own way and your own style serves, nobody any good.
Yeah.
And that, wider spirit of cooperation has benefits, more widely.
And I think just listening to you today and having a little bit of knowledge over a number of years, not only with yourself but with others in the community, it's getting stronger.
Yeah.
That spirit of collaboration is getting stronger.
Yeah.
And that, at the end of the day, that can only be good for the community.
Yeah.
Can only be good.
But I think not every individual person buys into that philosophy. And I think it's important that, we recognise that and try and, show them the benefits of working together. Sound very PC, don't I?
Name and shame. No, please don't.
No.
Please don't. What are you doing the rest of the day then? You've got your best skill shot.
Woods clinic.
You've got your clinic?
Yep. So an IBD specific clinic this afternoon. So we run them every week. They run in, all over Scotland, I think. So everybody has a weekly IBD clinic, which is a big focus of the week. And then we're able to see emergency patients, planned patients, and then make arrangements as needed from there.
So do you know who you're going to see today?
Yep.
Yeah?
Yeah, I do.
Yeah.
Well, maybe not. Kat might have. There's always space to see, people who need to be seen. So there might be a surprise or two.
So
that's the excitement.
How many do you normally see in a clinic?
10 to 12 patients.
12 patients. Just in the afternoon?
Or a morning.
Or in the morning?
Yeah. So in one session.
Would you, is there any way that you can, something that we hear quite often is that some people feel as if they don't have enough time. You guys. Is that something that you feel relevant?
I guess if people thought that, I'd like them to tell us, and we could look at how we could complement what we offer.
Maybe you're just a dynamic partner or whatever. Maybe it's just you.
Well, I think we want to give everybody as much time as they need, but also see everybody in the planned way. And I think sometimes you can see people who are in a difficult situation that needs more time.
Yeah, of course.
And then you organise, to come back at a different time. I guess what we've been able to do is offer different types of appointments as well.
Yeah.
And, we have a phone clinic which runs in parallel with a face-to-face clinic. And for some people, if it's a check-in, then they're quite happy to do that on the phone. Sometimes they like to do it on a screen, but actually most people seem okay on the phone, just chatting through things and that's it.
Yep.
And particularly if you're coming for a long distance, they still want to have that reassurance. Somebody's there in the background looking at the test, checking with the symptoms, but don't need to travel if everything's well. So I think having, both styles of clinic then allows people to choose what they need at that particular point.
Is there anything within the way that you do things just now that you would personally like to see implemented to improve?
I think more what we call point of care testing, I think would be the next helpful step for us. So for a lot of people, when they come to clinic, we'll say, okay, things aren't going so well just now. Can you give us this sample and we'll get the answer in 2 weeks' time? I would rather they could come to clinic, bring a stool sample with them, we do the test there, and then we have the result. Because then that makes the discussion more meaningful. So we sometimes try and do that and say to people, 2 weeks before you come and see us to clinic, no matter how you're feeling, we'll get that test done. But sometimes it's emergent, so...
I did my stool test the other day for my 50th. You get the
all right. That's not a good example to show to people, but so things can change over a short period of time. And if we're trying to make decisions on people in clinic, then if we can have the drug level or their inflammation level at the same time as clinic,
of course,
then it's a much better process. So you'll be happy to know one of the research studies that we're doing just now is trying to look into that. It's focused around liquid diet and looking at people through the liquid diet journey and seeing how well they're managing to take that liquid diet with one test and then another to see how well they're responding to it. Yeah. So it takes about 10 minutes to do that test, and we're really piloting how accurate the information is, but also how practical is it for families, because people don't like dealing with poo.
No.
And if we're asking them not just to put in a pot, but to pipette it out and put on a thing that looks like a COVID test, then is that really practical for children and families? So,
so what's that look like?
So it looks a bit like a COVID test. So you drop it on and then you wait 10 minutes and then you get your different lines or things on the kit. So it's an instant feedback. So we'll let people know how it goes. But for me, I think for young people, they would feel getting more of a holistic service if they can get all the results at the same time. So
that makes sense.
Yeah. It? So I'd like to see things move forward with that.
Well, that sounds super positive.
Yeah.
Super positive. So we get to the stage in the show. I never told you about this.
All right. Okay.
Think about it.
Okay.
Where we do the quick fire round.
Oh no.
Quick fire.
Okay.
Okay. First question. Who's going to win the league?
The Scottish Premier League.
Yeah.
Hibs.
Oh, don't be silly. Who's going to win?
That's my answer.
Okay. You're the most biased answer in the history of the world. Hibs. I mean, there's an argument for Hibs will never win the league.
Yeah, I know that, but that's my optimistic, positive answer based on a factual appreciation of where we've got to in the season so far. Next question. You've taken the credit. You've taken your credibility down about 20 notches. Okay.
You've been doing so well.
Thanks, Derek.
So is that your answer?
That's my answer.
Your answer is Hibs?
Yep.
Wow.
What's your answer?
I would like it to be Rangers.
Okay.
I find it unlikely.
Okay.
But I would like it.
Okay. So your answer isn't any better than mine. I feel like we're in Talk Sport now. I think we've gone from the Gutsy podcast into Talk Sport.
I felt it was relevant since I was at the football the other night.
Right. Okay. Okay.
It's fresh in my mind. And thank you for your kind hospitality.
Yeah. I thought you were looking to replace Ali McCoist on Talk Sport. Because that's kind of how I'm feeling.
Oh, he's very good, to be fair.
You're all right yourself.
Oh, thanks very much. That's very kind of you. Okay, 3 things with an inflammatory bowel disease that make you happy.
That make me happy. Good treatments, good teams, brilliant community.
Fantastic. 3 things that piss you off.
So lack of access to treatment, particularly for children. Hurdles within IBD research and not being able to give the answers families want all of the time.
Fantastic. And 3 things for the future. So
I think we've talked about some of them, haven't we? So I think a young adult clinic.
Yeah.
Fast access to treatments for patients of all ages. Not having these false barriers in place. And I think probably the third thing, I mean, is it prevention? I think probably what I would say is immediate feedback on how people are. So I think wearables and things which can give immediate information then is the future.
I think that would be phenomenal. Absolutely phenomenal.
We're also doing a research study in that slightly biased answer.
I knew you were going to say that. I knew you were going to say that.
Vested interest in every answer. It's shocking.
It's not just about you. Professor Richard Russell, thank you for coming on the Gutsy show. It's always a pleasure. You've been absolutely brilliant with myself personally and the foundation for many, many years, and you've made a brilliant impact. You're an absolute star of the IBD community, and I'm very proud to have you as a friend. Great to have you on Gutsy, and thank you for coming on.
Thank you, Derek, and thank you for everything the foundation is doing and will do in the future.
Thank you.